Hello and welcome. I'm glad you could be with us tonight. We're talking about Parkinson's disease tonight. It's a disease that has so many people wanting to learn more, wanting to hear about possible treatment options, and that's what our focus is tonight, talking about treatment options. Back with me is a wonderful local doctor. Dr. Eleanor Orehek is with us. She is at the Noran Neurological Clinic in Minneapolis on Chicago Avenue. She is also the medical director of the American Parkinson's Disease Association, the Minnesota chapter, and she is a movement specialist also. So she is a busy woman. When she was here before, we talked a lot about non-motor symptoms of Parkinson's, which I learned there are many, many, and we may have time to talk a little bit more about that tonight. But first, let's talk about treatment options. And I think most people are aware that right now Parkinson's does not have a cure.
Yes, that's right.
But can you differentiate a bit between the word cure and the word treatment? Because it's an important differentiation, isn't it?
It is important, and yes, you're right in saying that there's not a cure in Parkinson's, and so that's obviously in research what they're working towards and striving to get. But with a cure, you're trying to eliminate a disease or get rid of the disease itself. And with treatment options, you're either focusing on getting rid of the disease if that's what you have available, but you can also treat chronic diseases by managing the symptoms or managing the some of the consequences of having that disease. So
and that's also very, very positive, isn't it?
Yes, yeah.
I mean, when you can manage symptoms and
yeah, in Parkinson's we have a lot of good options that can manage the symptoms of the disease for a number of years. So
the fact that there isn't a cure yet, is that because we don't know exactly what the cause is? Because to find a cure, do you really need to know the cause, correct?
yeah, it definitely helps, because otherwise you're hoping to stumble upon it by chance. And so knowing the cause of the disease is really important when you're trying to figure out treatment options for that. And then, of course, if you're trying to get rid of the disease completely, learning about what causes the disease is important, and we're making huge strides in Parkinson's, learning about what actual changes are occurring in the brain cells and how the disease might start and progress. And so we're trying to find different ways of diagnosing it and tracking the disease, because that will help come up with better treatments.
When you talk about some of the exciting things that are happening, does one stand out in your mind in terms of exciting thread that you think may be followed by the researchers? Yeah,
so the disease is, one of the hallmarks of it is clumps of protein that start misfolding. So the protein is called alpha-synuclein, and that starts forming these clumps, and we think that's a big reason why the nerve cells start not functioning well and dying off over time in brains of Parkinson's. And so trying to target these proteins before they start misfolding or prevent them from clumping before they start causing problems for the cell is where one of the exciting directions research is taking. So there are several trials of different compounds that are aiming to target those clumps of protein, and some are in the forms of a vaccine type of treatment or an antibody type of treatment that could get at targeting those proteins. So,
where is the research that's really exciting? Where is it centered? Is it in the U.S.? Is it abroad?
Yeah, it's global, U.S. and globally. So a lot of the companies that are developing these drugs are headquartered in other countries, and then they'll have sites around the world when they're doing their trials, because it takes a lot of patience to get the numbers to show things are safe and effective. So they usually have a lot of different sites that enroll patients in trials.
I want to talk more about clinical trials a little bit later, but let's just talk a little bit about demographics. You and I were just talking, and more men than women are diagnosed with Parkinson's.
Yes, that's correct.
Is there any reason that is the case?
Not that we know of for sure. We've tried to look at women. Is there some role in estrogen protection, or what are men exposed more to certain environmental toxins or exposures, or farming, or certain things that we've linked to higher risk of Parkinson's or head injury? So there's different things that we're still trying to look at from an epidemiologic standpoint, but it's complex, so it's hard to know.
And the age that people usually have the onset, am I correct, it's in the 60s if we think of a decade
Yes.
being the biggest decade that it shows up?
Yes, that tends to be the average age, is somewhere in your 60s, mid-60s is the average age, but there's people much younger in their 20s or 30s that can be diagnosed with it, and people obviously in older ages can be diagnosed with it too.
I think because, well, I'm guessing because of Michael J. Fox and the amount of, knowledge he's brought to the public, people might assume that it's a disease that a lot of young people get, but that would be, it's more rare, correct?
It is much less common, yes, to have be diagnosed younger onset is about 10 to 20%.
Okay, 10 to 20. And what's the youngest you've heard about for someone being diagnosed? Can it go into
teenage
Into
years.
teenage
There
years?
tends to be other genetic conditions that cause kind of young onset of Parkinson's-like symptoms when you're talking about that young, but otherwise in the 20s is
It's considered
earliest I've heard.
Yeah, that's so young. That's very tough for those people. And in terms of just another statistical question, how long does it usually progress and continue getting worse? What's kind of an average length of dealing with it?
Yeah, I mean, it's hard to put a number on it because every individual patient is so different how long they live with it. I would say 15 to 20 years might be the average as far as living with it, but people live with it, like Michael J. Fox you brought up has lived with it for more than 25 years now, so there are people that live with it for much longer.
Is there any research out saying why some people do so much better in terms of having it progress more slowly, living with it more, for a longer length of time?
Younger onset seems to be, so there's some features that do seem to be linked with a slower progression. If you have tremor predominance, so a lot of tremor at onset or as part of your disease symptoms, then we seem to think that we've observed that people might progress or be able to live with it for a longer time. So there are certain trends that link either faster progression or slower progression, but generally it's slow progression, and people that are more active in exercise is one thing that seems to prolong being able to live with it and manage symptoms well. So I really push exercise when I'm talking to patients about treatments.
I know you mentioned that before when you were on, and I've read so much about the wonderful benefits of exercise, which that's a hopeful thing for people to hear, and important thing, isn't it, for people to
Well, and
get.
it's something people want to feel like they're being proactive and doing
Right.
something that's productive, and so
you have
exercise is one of those things. So
Yeah, you have some control over your body, which
Yes.
when it's kind of out of whack in a lot of ways, to have some control that you can
Yes.
take.
right,
I mean, not only physically, but emotionally important.
very important. Yeah.
We should maybe just have you mention, too, a couple of the related diseases, or maybe we would call them cousins to the traditional Parkinson's disease.
Yes.
Because a few of those are very short, lasting in terms of how aggressive they are. And what are a couple of the more common ones?
Well, there's one called progressive supranuclear palsy, or PSP, which can have symptoms that look similar to Parkinson's, but when you're talking about the root cause in these abnormal proteins, it's actually a different protein. Multiple
But
system
still a
atrophy.
protein-related
Yes.
cause.
Yeah, exactly.
Okay.
And multiple system atrophy is fairly closely linked with Parkinson's, and that's both of those. When they're early, you might not know that it's those cousins, you could call it, to Parkinson's disease. So following patients over time and looking for signs that it's an atypical form, we also call it atypical Parkinson's syndromes, then that can give us an indication that progression might be different or not respond as well to some of the treatments we have.
I've not heard of the multiple
System
atrophy. Can you just, in a nutshell, define that for me and for the viewers?
Yeah, so that one does cause the protein, the same protein involved in Parkinson's is involved in MSA, we call it for short. There tends to be a lot more problems with the autonomic nervous system in MSA, and that controls blood pressure, heart rate, temperature regulation, bowel, bladder, and so
things that are kind of going on that we're not consciously working to control, right?
Yeah, exactly. Yeah, so that is more affected in people with MSA than in Parkinson's. Even though in Parkinson's that can is a big section of non-motor symptoms that people can be affected with as well. So,
okay, so those are three that are out there that we don't know as much about. Well, the kind of, would you call it a gold standard, the medicine, the drug that most people with traditional Parkinson's take is called Sinemet, or
carbidopa-levodopa would be the generic name for it. So that it's been around since the 70s.
And it's still the main one, isn't it?
Still the mainstay, because it is, levodopa is the form of dopamine that gets into the brain, that can cross over into the brain and then gets turned into dopamine. And dopamine is one of the main brain chemicals that people are lacking in Parkinson's. And so it can be very effective at treating the motor symptoms.
And we hear about dopamine in different ways beyond the Parkinson world, don't we?
We do.
But it's a chemical that brings pleasure too, isn't it? I mean, it's...
So there's different pathways that are dopamine's involved with. So there's a reward pathway that is involved more with the pleasure surge. So if you win in gambling or have a sweet food that's good, then you get a release of dopamine, and that's in a different pathway of the brain that's infected in Parkinson's.
Okay, but still a positive effect.
Yes,
So can you have too much dopamine? Does that...
You can,
That can be a problem too then?
Yes, well, and that's what can be challenging about using carbidopa-levodopa. As the disease progresses, your brain doesn't handle it quite as well, and you become more dependent on the pill form or the medication form of it without your brain having its own dopamine, and so you can get fluctuations in motor response. So you can get extra movements that are the dyskinesias. That's what Michael J. Fox has a lot of. That's a side effect of the medication that can come as a result of disease progression and then being on higher doses of the medication.
So at some point then people can't get enough of the Sinemet to control the symptoms because of the long-term use. Is that a way to put it?
Well, it's almost that you can't find the sweet spot anymore because you have a window of where people feel good without the side effects of the medication, and that window gets narrower and narrower over time. So you're either on the top side of it or the bottom side of it, and not right in the middle. And so that's when it gets more challenging to use the pill form of the medication. And so they've developed newer treatments, and there's a gel form of carbidopa-levodopa that can be infused directly into the small intestine that provides that even level so that you don't have as much of those ups and downs. And then they're working on a patch form of the carbidopa-levodopa that would provide that same effect and be a little bit less invasive than the gel.
Kind of like in the world of diabetes where they can even out the insulin dosages.
Yes.
Well, those are positive developments, aren't they?
Yeah, they are.
And not
yeah.
something I'd heard about before. Well, exercise continues to be, as you said a few minutes ago, really, really important. Are you finding as a physician that your patients are willing to really up their exercise? Because I'm guessing most people in their 60s or 70s or 80s aren't exercising as much as they maybe think they would like to or should. And then you add this diagnosis and there's pressure.
There is pressure, and it's a good question because I think the disease itself can cause apathy or lack of motivation, which makes it harder to motivate to exercise, but knowing how important exercise is a big motivator too when you have aging plus Parkinson's. So I think that is enough to get people over the apathy, and get out there, and it helps. I follow up with people, so I make sure to talk about it at each visit and check in on what their exercise program is, because that helps, and helping them connect to exercise groups or classes or personal trainers, or starting with a physical therapist that can show them good exercises to do at home can be helpful. So people start at different levels of activity, and then we try to work from there.
Yeah, I would think, just having exercised quite a bit in my life, that having someone to be accountable to, whether a partner that you're going to meet and run or walk with, probably not run when you have Parkinson's.
I have a few that still run or play
few?
tennis or do things, but not very many.
But having someone that you go to a class with or take yoga with or whatever, I would think would be important.
It is. It helps a lot. I have some that can motivate themselves, but most do much better if there's someone else that's helping hold them accountable to the exercise program.
And as a doctor, if you're checking in with them, that's motivating too. I think most people want to please their doctor and be good patients.
It helps anyway.
Yeah, I would think. Some physicians in some fields, I think, don't talk with their patients enough about exercise, about diet, about sleep, about some of the basics. But it seems in the field of Parkinson's that you're on that, really.
I try to be, because it's just one of those priorities, at least for me, when I'm talking with patients. But for some visits, I think it gets pushed down, and then there's not time to get to it or other things.
There's so many. Every patient, I think, comes in with either a mental list or a written list, and
so you might not
time
get
is
to
tight.
it.
Deep brain stimulation. We're hearing more about that. I think a lot of people are very excited about it. There is a window, though, isn't there, where it can be used most effectively?
Yes, there is, and that window has shifted earlier than it was 5-10 years ago, because there's been some studies that have come out showing how beneficial it is to do even earlier in the disease, and they compare people that are on what we think is the optimized medication plan, and then people that get DBS, or deep brain stimulation plus optimal medication, are doing better on their motor testing and quality of life scores over that 3 to 5 year period that they're studied. So, and we're getting better at being safer with it, and not having as much complications with the surgery. So I think that's shifting to do it in earlier stages.
For those who may not know what deep brain stimulation is, just again in a nutshell, can you explain how the electrodes are put into that deep, deep part of the brain and what goes on?
So you can think of it kind of as a pacemaker for the brain. So it's still connected to a battery that's in the chest, but the wires are going up into the brain, and they're put into the brain through a small hole in the skull. And we use MRI guidance to target these areas, and then the surgeon has a frame that's used to plan the targeting, so that during the surgery, he's already planned out exactly, or she has already planned out exactly where the wires are going, or the leads are going, And then there's some testing that we do in the operating room, which I would be involved in for patients with Parkinson's, that confirms that that's the right place.
So the patient is still awake.
Yes.
Usually, right?
Right.
During the surgery, which sounds a little terrifying,
It
perhaps
is.
to some people.
Yes.
But
it
they're
is.
not feeling any pain
Exactly.
because the brain does not have
pain
pain
receptors.
receptors. Yeah, I didn't know that.
Yeah.
But so the doctors are talking to the patient, asking, can you what are you asking the patient?
So one step is that we can listen to the different areas of the brain, and that we have a recording device that helps map out where we are in the brain. And so if you're asleep, that goes away. So we need people to be awake for that part, and then to confirm testing, we're having them do kind of hand movements or look at their tremor. Does the tremor go away? And we do it for essential tremor too, and so you can do writing task or spiral and see as you turn up the stimulation what happens to your symptoms. And obviously you like to see that the symptoms go away.
Right.
So, and usually we do.
And they usually do. I mean, and that's what's really exciting.
Yes.
But it's not, when we talk treatment versus cure, and those two words we started the show with, it's not considered a cure.
Right. That's an important point, because there are some studies that are trying to look at whether it might slow down the progression of the disease, so that hasn't been proven, but there's some suggestions that it might. But the disease does continue to progress. So over time, other parts of the disease become an issue that the DBS doesn't necessarily manage. So.
And DBS does not control or affect all the symptoms either. It affects the tremor primarily.
It affects the tremor, but you don't have to have tremor to be a good candidate.
Oh, okay.
So in Parkinson's, if you have muscle stiffness and some of the slowness, like difficulty in moving your hand or with walking, it can be really effective at treating that. And then the muscle stiffness that people live with kind of constantly that no one else can see, that tends to melt away with the DBS. So.
But it doesn't affect balance, I read. Is that still true?
That's true. Yeah.
Okay.
So if your big problem is postural instability or balance problems, then it won't be very effective at treating the balance problems and a lot of the other non-motor symptoms of the disease.
I am getting the signal that we're getting close to out of time already. I want to quickly, though, ask you about clinical trials, because there are some exciting things on the horizon, and you've mentioned some of them already. But what's the one that's most interesting to you?
Well, I think the ones that are targeting these clumps of alpha-synuclein are probably the most exciting and interesting, that I think are over the next 5 to 10 years potentially going to turn into an actual, I don't know if I would say cure, but at least slowing down the disease progression or halting it. Stem cells come up as potential treatment, and that's an exciting area, but I think we're further out from actually getting to a point where we're using that as a treatment option. And then looking at newer and better forms of deep brain stimulation, different device adaptations and technology they're developing, so that's all exciting.
So when I look into your eyes as you're talking now, and I see your eyes start to really light up, then that makes me think, yes, there is some really hopeful stuff on the horizon that I think we all need to hear hope when we talk about this disease.
Definitely,
And,
yeah, there's a lot of reason to have hope for
yes. I want to give some resource info to you, and I think I won't read all of these, but we're going to put down some key places that you can get more information about the disease, about support groups, about classes, about things going on in the area. First up will be the Noran Neurological Clinic, where Dr. Orehek works, and that's noranclinic.com. That's an easy one. Then we're going to put up the American Parkinson's Disease Association, and that is apdaparkinson.org. And then we're also going to put up the Minnesota chapter of that national organization. And I'll let you just take note of that. That's a long one. There's also a phone number with that. You might want to note this, 651-241-8297. And then the Parkinson Foundation, another national group, and that is just parkinson.org. Well, thank you so much for coming down. We've got maybe a minute left. Is there anything in the arena of hope that you think we should say to people as we say goodbye?
I would probably just say keep fighting, keep working with. It's important to have a good care partner or spouse, friends, family. Surround yourself with a good network of people with support, and make sure they're taking care of themselves too, because that only makes things go better for everybody. And a good care team is important. So I think there's a lot of interesting, exciting things happening in the world of Parkinson's. So.
And don't be afraid to ask for help. Probably is a good thing to say to a patient and a family member.
Mm-hmm. Yeah, definitely. And having a good relationship with each other and your doctor are important.
Right,
yeah.
For sure. Well, thank you so much for coming down again.
My pleasure.
It's been so interesting, and I've learned a lot, and I know the viewers will have too. So thank you.
Mm-hmm.
Thank you for being with us. I'll be back again next week. Until then, have a very good week, and check out those websites. They're very, very helpful. Bye-bye.